Radio Brockley, now officially London's #1 hospital radio station.
Hello and welcome to Brockley News, Radio Brockley's weekly show, keeping you up to date with all you need to know about what's happening in and around the hospital. I'm Alan Joyce, and coming up today we'll be hearing about the hospital's Research and Development Day, which happened last month. Ron Laver and Sue Weston spoke to some of the people involved, and we'll be hearing from a number of speakers at the event and hearing about some of the amazing innovations as well. You'll be hearing the highlights over the next half an hour. Then at 8:30, your chance to win some Radio Brockley goodies without leaving your bed. It's Bedside Bingo. Keith Reeve filling in for David Rauch tonight. Your patient rep should be up with you very shortly as well. And then at 9 o'clock this evening, it's all your choice of tunes on the Sunday Request Show, and Keith Reeve will be here again for that. So stay tuned to London's official #1 hospital radio station, Radio Brockley. So on Thursday, the 3rd of April, the RNOH staff and guests from partner institutions and supporting organisations attended the first RNOH Research Day. Attendees were given an inside view into some of the latest research and innovations currently underway in the field of orthopaedics. Our reporters Sue Weston and Ron Laver went along to find out more. So let's join now Ron Laver to find out more about what happened on the day.
I'm here with Eva Hatmanova, who is the head of R&D here at the RNOH. Eva, what's going on here today?
Well, we're having a very exciting day. We're having our first research day in over 10 years, I think. So we had some last-minute hiccups, as one would expect, but we've got lots of exciting presentations about projects that are currently happening. We've got some exciting videos of some lovely patients who have been helped by some of the products that have been designed here. And hopefully we're going to have lots of people coming to learn about what we do.
You're expecting a big crowd here today?
We're expecting probably over 50 people.
And this is going on all day, isn't it?
Yeah, so we're starting at 10 o'clock and going till 4:30.
Okay, and who are the people who are presenting?
So we got a mixture of people. We have some of our clinicians who are going to be talking about the projects that they're involved in. We've got some of the academics that we work with, some of the developers of the products as well. So we got quite a good mixture of people who have different involvement in the projects that we are working on. And we're kicking off with Professor Goldstone, the chairman of our board, who knows how important research is to us.
Okay, well look, I'll let you get on because it's a busy day, and we'll try and catch up with you towards the end and see how it's gone.
Thank you very much.
Okay, good luck. Thank you. I've grabbed Tony Goldstone, who's the chairman of the RNOH Trust. Why is this day today important for the hospital?
Well, in order for the hospital to retain its status as a very major international centre, we have to really give a greater emphasis to clinical and basic research than we've done over the last 20 years or so. Everyone knows that the clinical work, the surgery and the therapies are outstanding, but a national and international rated centre must be something which contributes to innovation in the specialty as a whole. There are so many things going on here. We want to harness that activity into studying new technologies, bringing in new techniques, and generally using research to advance the frontline treatment for the most complicated of patients. So we want to enhance the profile of the hospital as a world leader and support and amplify the culture of the hospital as something which deals in research and innovation and will be attractive to those with the most difficult clinical problems.
So is today aimed at people, clinical staff within the hospital today, to try and encourage them to take on projects and research?
Yeah, today is aimed at virtually every member of the hospital staff, some of whom, big numbers amongst the therapy staff and the nursing staff, may never have thought themselves to really have the skills to be involved in research, have the interest to be involved in research, and see its relevance to what they're doing on a day-to-day basis. So we really want to enthuse the whole staff today, particularly those not involved in any research so far, that they can contribute to innovation, do something new, and the end result of that will be better treatment for the patient. Amongst the 100 or so therapy staff, there are people doing things and looking at techniques who are more skilled in their own particular area than almost anywhere else in the UK. And sometimes in the clinic arbitrary decisions are made whether this patient should have surgery on the shoulder or this patient should have 6 months physio instead. We want to kind of start the staff thinking about the culture, looking at some of these routine decisions and say, well, how do we know this is better for this guy and this other thing's better for this woman? Let's study it properly and let's give half of them this and half of them the other treatment and let's really find out. We also want to increase their pride in working in a place like this so that they feel it is an outlet for clinical innovation at the highest level. The two terms, the Royal National Orthopaedic Hospital, has to mean something. It does mean something. This is a special place, and the things that make it a special place are the level of clinical work and its research. Research today, clinically, is not done by one individual or one boffin in a laboratory. Research is done by a team of people who are looking in a complex, well-structured way about a study which answers a basic question. Is it better to operate on the patient to do this, or is it better to put pins in the joint to immobilize it? These kind of things which have never been answered properly in surgery, we want to enthuse the whole of our staff to say, hey, hang on a minute, I can contribute to this kind of thing, because a research-based culture is essential for the whole of this institution from bottom to top, so that it retains its position as really a centre of international standing, which is certainly what I want for it and what all the senior staff want for it.
Thank you very much for your time.
Pleasure.
Thank you. As you can imagine, there were a large number of projects discussed on the day, too many for us to cover here. So we decided to concentrate in particular on one called TAVA. Sue Weston caught up with a couple of the researchers.
I'm here with Deirdre Brooking, the Trials Coordinator in the Research and Innovative Department. Would you like to tell us a bit about the role that you have in that department?
Yes, hello. This is a new role I took on board in January. We're about to begin a 5-year study working with the foot and ankle team, and my study is called TAVA, which is comparing total ankle replacement versus arthrodesis. It's a £3 million project funded by the NIHR and our lead consultants are Andy Goldberg, Dishan Singh and Nick Cullen. We should be looking at how total ankle replacement compares to arthrodesis, which is also known as ankle fusion. At the moment, there's currently no patient outcome data to see who fares better in these processes. Fusion has been taking place, or arthrodesis has been taking place for quite some time, but ankle replacement is a somewhat novel procedure. And we're looking at cost effectiveness, best patient outcome, how they cope better with pain afterwards, and then basically to see if their quality of life is improved and if there's any major differences between the two procedures. I'd like to introduce Claire Thompson, who is our clinical trials manager for TAVA. She's part of UCL Comprehensive Clinical Trials Unit.
Hi, well, I've been working with Deirdre since earlier this year, and we've been working on developing the study protocol. So the aim is to recruit 328 patients from up to 15 NHS hospitals in England as Deirdre mentioned, to compare total ankle replacement with ankle fusion and find out the best results for patients. So this study will begin recruitment later on this year, and we will follow patients up for 52 weeks and compare the outcomes at the end of that year. So patients will have various questionnaires to complete regarding their foot and ankle and the levels of pain they experience and their quality of life, and they'll also have their ankle mobility measured at the start and end of the study. So yeah, we're really looking forward to getting started.
Thanks very much, both of you.
Good morning to everybody. Welcome to the RNOH. I'm Tony Goldstone, the chair of the Trust. This is a very important and auspicious day, hopefully the first of many research-based days, which is trust-based, NHS-based, as well as being in association with the university UCL. The introductions will be done by myself and Professor David Eisenberg, who's here, one of the board's non-executive directors, and I want to him and Alistair and Gordon and Eva over here for all their efforts in upgrading over the last few years much of the translational research effort that this hospital does into nationally recognised clinical studies and clinical trials. Now, it's quite clear that in order to be internationally rated clinical centre in any specialty, there are various things that you have to have. One is a top-rated specialist clinical service, which we have always believed has existed at the RNOH. Sometimes it is just that we have believed that it has existed, and it certainly does, but not necessarily with all the research, trial and clinical evidence to prove that that's actually the case. And a philosophical change is now taking place to be absolutely certain that we can show where we claim to be the best, that we are actually the best. For many years, we've had a lot of high-quality clinical research. Two of them, I would welcome two of our most senior people here, Michael Craggs and Adrienne Flanagan. It is probably little known by the 1,300 people on the campus that the most prestigious piece of orthopaedic research coming out of this institution at the moment comes out of the pathology laboratories and not the operating theatres. The genetics of some of the malignant tumours, some of the work which has been carried out here is truly world leading, and I'd like to pay particular tribute to Professor Flanagan and her group for that. So to go back to what constitutes a first-rate centre, a first-rate clinical service doing innovative things to which the most difficult and complex patients wish to be referred because they would hopefully get something that they don't get elsewhere. And we're going to hear about some of that today. Secondly, you have to have an association and a high-profile academic department. As I've already said, we've had many elements of this in orthopedic surgery, in spinal cord injury, in tumor genetics, in genomics over many years. But if you looked from the other end of the telescope for around the folk associated with the specialist units at University College London and some of the other allied health science centres, you would have to accept that over the last few years the profile of the RNOH has not been, as a clinical institution, at the level of some of the major American and European centres and at the level in other specialties of, for instance, the Marsden, Great Ormond Street and Moorfields. We are determined and are already showing evidence, which some of which you'll see today, that the profile of this institution will be back up at that level as a retention and indeed a burnishing of the nationally and internationally recognised brand. And the third thing that you have to have to be accepted as a world centre is to be able to accept the most complex international patients, and to do that you need a non-NHS private facility, and again it's on the agenda to upgrade that in a major way at the RNOH. The last thing I want to mention, and you'll hear some of it today, is that we have not had the same level of randomized trials of different therapies in the surgical specialties as we have over the years in the medical specialties. And it may not be completely clear that for a variety of orthopaedic interventions, it's better to do an operation than not to do an operation. And you're going to hear a little bit today about trying to look at that properly so that there becomes real evidence that any surgical intervention is better than any other way of treating the patient.
The hospital's chairman, Professor Tony Goldstone, speaking there. We'll have part 2 of our piece on the hospital's Research and Development Day coming up very shortly. This is Brockley News, and still to come this evening on Radio Brockley, we've got Bedside Bingo coming up in, about 15 minutes' time. Your chance to win some goodies. Keith Reed filling in for David Rauch today, calling out the numbers, giving you the chance to win. Hopefully you'll see one of the patient reps. And if you don't win on Bedside Bingo, don't forget you've still got a chance of a consolation prize in the form of a request. The Sunday Request Show coming up at 9 o'clock this evening, and Keith Reed in the hot seat for that as well. Let's bring you part 2, though, of the R&D Day. And next we hear from Mr. Andy Goldberg.
So I'm here to tell you about TAVR. Hip and knee arthritis typically is in your genes. You're going to get it and it's going to happen to you, whereas ankle arthritis is as rare as hen's teeth, actually. And it was this misunderstanding that because it was rare as hen's teeth that anyone would perceive, why fund a study on a subject that's rare as hen's teeth? So our task is to make people realise that that's a wrong statement, which is a perception that you have to then change. So that's your starting point if you're going to run a clinical trial. And in fact, ankle arthritis is very common after injury to your joint. So as soon as you disturb God's very clever symbiotic relation, the way the ankle works, the ankle wears away rapidly. Within a few years, as soon as you've had repeated strains or ankle fractures, which happen to young people, and therefore it typically affects people and becomes more and more symptomatic as you get over the age of 50. There's an X-ray showing you complete loss of the joint space. So a normal one, person standing there, the reason there's a gap there is not because there's a gap, it's because the two bones are held apart by a shock-absorbing cartilage on either side, and on this side you can see it's not there and the bones are rubbing against the bones. Does it affect people's quality of life? And you have to be able to demonstrate that it does.
Before I had the surgery, I couldn't walk very well, and we do like walking. We had a dog at the time that's died since, but we used to walk her quite a bit.
He's up and down the stairs, not being able to drive a car, no gardening, nothing around the house really, except standing in the kitchen and trying to help out there or sitting in a chair.
All that I could do before was, say, just sit and rest really. I couldn't go and do to the shops very easily, comfortable. I couldn't walk about for very long at all. Every footstep was agony.
And that's the point, is that ankle arthritis actually affects your quality of life as much as hip arthritis, congestive heart failure and end-stage kidney disease. Okay, and that was some nice work that was done out of Canada, and that was a forerunner for us. And the next question was, well, how common is it? And actually there was no information out there. The only thing that was out there, as I said, was that it was rare as hen's teeth. So we had to do some work, some preliminary work. This is going back now to 2007. We did some preliminary work to show that 29,000 patients a year were presenting to specialists in the NHS with ankle arthritis. And that suddenly, we got that published, and that then set the scene that this is not a small problem. Most people, however, the 29,000, don't end up needing surgery. So the standard treatment for most people is physiotherapy, weight loss, braces, painkillers, etc. And it's only a small proportion of people that end up with what we term end-stage ankle arthritis. So, as Tony said this morning, it's important to know that certain things, surgery may not benefit people, but this is actually a condition where everything else has been tried. And at that stage, you don't have any alternative but to look at a surgical solution. Treatments when you've got end-stage arthritis where nothing else has worked, okay, and that's ankle fusion, and that's the gold standard treatment for ankle arthritis. A more newer technology is ankle replacement. As it happens with ankle fusion, you have 30 joints, some would say more than 30 joints in the foot, so even if you take out one joint, you still have the other 29 to adapt, and so you don't lose all your motion. You don't. So it's a very successful operation. You retain about 50% of the motion with fusion, but a replacement retains the motion back at the ankle joint. The problem is that there are numerous techniques to fuse a joint. There are numerous ankle replacements on the market, and there's no evidence out there as to which one's better for patients, and there's no evidence out there as to which one produces the best results for patients or the NHS. So we put together and set up a national joint registry for ankle replacements, which is now part of the National Joint Registry, and that's leading the way. This is a national activity that has more than 1.5 million joint replacements, hips, knees, shoulders and ankles on its records. And so we capture now every patient that has an ankle replacement goes onto that. If you have your ankle fused, it doesn't go onto that because it's not a joint. And the other issue is that this produces hard endpoints. So this tells you that, you know, the likelihood that an implant will fail. But it doesn't tell you really about the touchy-feely things. It doesn't tell you about whether the patients are happy or not happy, whether the patients are satisfied, able to get back to work and get back to their activity. And so these have limitations. And if you're going to start to find out more information, then you've got to do some form of clinical trial, which is where we started from, really. What's the research questions that we're going to ask? Does ankle replacement lead to better patient outcomes in comparison to the alternative treatment? And most importantly, if you're going to apply for an NIH HDA grant, you do need to be able to look at cost effectiveness, because that's an important metric in an increasingly health conscious National Health Service where resources are going down and demand is going up. And one of very importance to me was this: if you have an ankle fusion and you stiffen the ankle joint, by definition you retain motion because you've got the other joints, but you do put more stress on the other joints, which then will wear with time. And that's the biggest concern I've got in fusing a very big joint, is that you may then develop pain and come back after a few years after you've worn away the other joints, and what do you do then? So to me, that was one of the most important questions. The problem is that's a long-term question, and you can't answer that in a clinical trial of a finite period. So the good thing is that once you've set up a clinical trial, you can answer a whole series of additional questions later on, because you've now got a cohort of patients with very vital information that you've captured. I mean, this is truly a national trial, but this is truly a world-class trial. And the reason I say that is that there hasn't been a trial like this anywhere in the world. So there's centres across Scotland, England, Wales, and across the UK. So that's it, really. And I'd always like to give the final words to the patients. So I'm just going to... Tony, you said that this is a place where we don't tell enough about what the patients do. These are the patients that have had their surgery. So the final word.
Since the operation, I have landscaped our back garden completely, and relaid it out with pavings and walls and so on. That's been really a pleasure to do.
I can go out for walks. I can do my own shopping, which it was getting that because of the weight carrying shopping, I couldn't do it.
I don't feel disabled now. I can get on and do most things. I still get tired towards the end of the day, but I'm not sitting like I was sitting in here with my feet up in agony, throbbing all the time. Yeah, I don't know. I'm lucky that he was able to do that for me.
So I'm here with Andy Goldberg now. We're talking about TAVA and what that involves, and about the research that you do.
The clinical trial is called TAVA, and TAVA stands for Total Ankle Replacement versus Arthrodesis, which is the other word for fusion. It's a 4-year study funded by the National Institute of Health Research, that's the NHS, to the sum of more than £2 million. So this is a clinical trial. So in medicine, the way that we determine which treatments work best is to run a trial comparing a treatment against either no treatment or 2 treatments against each other. Now, that's the only real way that you're able to move forwards and establish which treatments are the best interest of the patients. So my trial is in an area called ankle arthritis, and just like any arthritis is where the joint lining, or the shock-absorbing joint lining, called cartilage, in any joint wears away. You get bone rubbing on bone, and that causes pain and stiffness, which is the symptoms of arthritis. And if that happens in the ankle, then it's very debilitating. And in fact, it's been well shown now that ankle arthritis means you can't walk to the kettle to put on the kettle and make a cup of tea, you can't walk to the shops to do your shopping, get up and down stairs, and life's miserable.
The research that you're doing is between 2 different types of intervention?
That's right. So the mainstay of treatment for ankle arthritis is non-operative, so it's with measures such as weight loss and changing your activity level using a stick or a brace around the ankle and painkillers, and most people do very well from that. But when all of those treatments have failed, then you're left really with the option of having surgery. And then there are two surgical treatments that are accepted. Both are used on the NHS. One is where you remove the remaining joint and join the two bones together in the ankle, and it's called fusion, where you join the two bones and they become one. By definition, there's no movement after that procedure. The alternative treatment is a replacement, where you resurface the joints and they have a gliding surface in between made of plastic, and that means motion is retained. And what we do know is that both treatments offer a very good outcome for patients, and both are successful. What we don't know is which treatment patients prefer, and what we don't know is which treatment is most cost effective, meaning which offers the best value of money for the NHS.
If patients are listening now and feel that they could be put forward for your research, how would they go about contacting?
So we have a research office at the Royal National Orthopaedic Hospital. All they'd have to do is ask to be put through to the research office. There's a website for the research office, and we have an email address, which is tarva, TARVA, at rnoh.nhs.uk.
If people can get in contact with you, the more people you have with your research study is better, isn't it?
Absolutely.
Thank you very much.
Well, I'm back with Eva now. It's been quite a long day for you. How has it gone?
It has been a very long day, and considering how worried we were this morning, is anybody even going to turn up? It's been a really great day. We had lots of positive comments from people, so I think it's been a great success, and we hope people learn a bit more about what we actually do.
There's a big crowd as well, because they were struggling for places on one or two of the talks, weren't they?
Well, that's good to hear.
And what are you hoping as an outcome from this today now?
Well, we hope that people are now a bit more aware of what we actually do and how some of the interaction with the scientists and the clinicians works. It's not always easy relaying the information, because once you start going into the very scientific, you lose quite a lot of people, and it's not always easy to see how some of the baffling science people talk about, how is that actually going to be useful at the end of the day. So we hope, even if we dazzle people with some of the science, that people realise how important lots of that work is to make sure we can improve patient treatments.
Well, I think as a layman that came across to me, and I found it interesting, even though, as you say, at points the science does get a bit baffling, but there was enough in there for lay people to understand. And of course most of your audience are not lay people, they're hospital people anyway.
Yes, and it's good to know that you say that it was interesting and that the points came across, because it's even people from different disciplines don't always get the points that people from other disciplines are talking about. So it's important for us to be able to relay the information in a way that is understood by everybody, really.
So what's the future now? Where do we go from here?
Well, the future, a bit like the hospital, we're hoping we're going to get our premises which are fit for purpose. So we have the new academic building has now been approved, and we're talking to the architects, which will hopefully enable us to have more people and even better facilities than we have now. Because we've been doing a lot of great work, even in the buildings we have now is not just about the building, so we need to be getting in more people, attracting more people, and hopefully we have been doing that, because over the last few years the Institute has grown, the Institute of Orthopaedics has grown, as has the research support at the site, is pretty much grown about 90%.
Okay, well, good luck with that, and when you're in the new building we'll come and visit you.
Yes, you'll be most welcome. Thank you.
Thank you, Eva. Bye now.
Fascinating package, that, and a massive thanks to our reporters Ron Laver and Sue Weston for their work on it as well. If you want to catch up on that and other previous editions of Brockley News, you can do by going to our website, radiobrockley.org, and following the links to our YouTube site. Plus, you can catch Brockley News Extra 5 days a week at midday for another chance to hear some of our recent interviews. Next week on Brockley News, we'll be hearing from Brian Carlin from the Aspire charity, who was attempting a 12-hour cycling challenge, and we'll also be hearing part 1 of our monthly news series from the Disability Foundation about their therapy of the month. Stay tuned to Radio Brockley. Bedside Bingo coming up next with Keith Reeve, your chance to win some goodies. Good luck if you're playing along. And then at 9 tonight, Keith's back again with the Sunday Request Show. From me, Alan Joyce, though. Good night.